Hello, I'm Dr. Manikan Swami, consultant orthopedic surgeon and faculty at NEXTFELLOW. Coming to the question, 85 years old woman falls onto her left hip or the ground during her regular daily walk. An injury radiograph is shown in the figure. What is the best long-term solution? The three main key points in this question is she is 85 years old woman. Number 2, she is taking regular daily walk. That means she is physiologically active lady. Number 3, he is asking a best long-term solution. That means the treatment that offers permanent or long-term pain relief and mobilization and reduced reoperation rates. Okay, look at the picture in the down. Look at the left hip. There is a breakage in the Shenton's line and breakage in the trabeculae. There is a fracture neck of femur in the left hip. There are four options available. I will explain in detail in the later slide. Believe me, fracture neck of femur is a bigger topic. You will require a lot of understanding. It takes some time. Bear with me. A few key points regarding fracture neck of femur. As we know, the hip joint is a ball and socket joint with inherent stability. The capsule and ligaments of the joint provide additional stability. The acetabulum faces an angle of 30 degrees outwards and anteriorly. The normal neck shaft angle of the femur is 125 degrees in adults with 15 degrees of anteversion. That means the head of the femur rotates anteriorly about 15 degrees from the coronal plane. And one more important point regarding fracture neck of femur is decreased healing potential because of the following reasons. The fracture neck of femur is intracapsular. It is bathed in the synovial fluid. The synovial fluid contains some important chemicals that inhibit for blood clot formation. As we know, the blood clot formation is the first step in the bony healing, which doesn't take place. And next one is the femoral neck doesn't have a periosteal layer from which the callus formation will take place. So all these factors leading to high chances of non-union in the fracture neck of femur. Anatomical classification. It depends upon the position of the fracture site. If it occurs between the head and the neck, that is subcapital. If the fracture occurs between the neck and the greater trochanter, that is basal fracture. If it occurs in between, that is transcervical fracture. Coming to the Pohl's classification, it depends upon the angle between the fracture line with the horizontal. More the angle means fracture line is more vertical. More vertical the fracture line, the fracture is more unstable. I will explain why. Look at the picture 1. If you press the head down, what will happen? The fracture becomes more compressed and fracture pattern becomes more stable. In the third picture, if you press the head down, what will happen? The head slides down and get displaced. In this kind of fractures, we have to do an osteotomy. That means we have to take a piece of bone out to make the vertical fracture line more horizontal. Gardner's classification, we have four types of fracture patterns. First one is incomplete fracture, other three are complete fractures. Coming to the clinical features, the patient who sustained fracture neck of femur will complain severe pain in the groin, usually come to the casualty with a stretcher or a wheelchair. If you observe, the leg is shortened and coxally rotated. That means patella is faced outwards. That there is a tenderness in the groin. If you attempt the movements of the hip, they are very painful with severe spasm. If you ask the patient to raise the leg, which is not possible. These are the various kinds of implants used to treat the fractures around the hip. If you look at the first three images, they are used to treat the fracture by fixing it. First one is the cannulated screws, and second is sliding hip screw, and third is intramedullary nail. Coming to the hemiorthoplasty and torticoloplasty, in the surgeries we take the head completely out. As in the hemiorthoplasty, as the name implies, hemi means only off. That means we prepare on the femoral side, we insert the process in the femur only. So when the patient is walking, the movement occurs between the patient acetabulum and the prosthetic head. So gradually the head eroses the acetabulum. The patient in the long term complains pain in the groin and limping while walking. In torticoloplasty, we insert the process in both acetabular side and femoral side. So the movement occurs between processes only. So the patient will be pain free in long term. Coming to the treatment, if the patient is very young, like less than 60 years, we should always preserve the head by fixing it, because young people will have a healthy articular cartilage and good bone stock. But we have to counsel the patients. They might be having a non-union, or head may goes into the non-osteonecrosis. That means death of the head. Okay. In elderly people more than 60 years, we cannot opt for the preserving the head, because the bone structure is very poor and the articular cartilage might be damaged already. We should think between hemi-orthoplasty or total hip orthoplasty. In hemi, we have to do for the low demand patients. In total hip, we have to do for the patients with good physiological activity. Coming to the options, our lady is 85 years old lady, so we cannot fix it. We have to replace it. So we can rule out first two options, cannulated screws and valgus intertrochanteric osteotomy. Both are used to fix the fracture. So next we have two options remaining, 3 and 4. Our lady is taking a daily walking. She is physiologically very active. So we have to rule out option 3, unipolar hemiorthoplasty. So total hip orthoplasty is the answer. So it offers long-term pain relief, good functional outcome. So answer is option 4. I already briefed regarding indications of various implants. Now I'll go through every answer. Answer 1 is cannulated screws, which are indicated for only younger populations. We don't use fixations for the elderly people because of various factors like damage to the arterial cartilage, bone stock, fracture angle, comminution, blah blah blah. There are many factors are there. We just use fix to younger population and not for the elder people. Just remember that. And answer to valgus intertrochanteric osteotomy. It is also type of ventral fixation only. This is a technique where we will convert the vertical fracture line into horizontal. I already explained this in the Powell's classification. So it is indicated in younger population. Answer 3. Unipolar hemiorthoplasty. It is reserved for very low demand elderly patients because as I told that artificial head directly articulates with the native acetabular bone. During movement, it gradually erodes the acetabular cartilage and bone. The patient develops groin pain and limping. So eventually the patient develops pain and limping while walking. So it doesn't offer the long-term pain relief. And last option is total hip orthoplasty. I already briefed regarding surgery. It offers the best pain relief, fewer reoperation rates, and best survivorship if you operate it properly. Okay.